And without any further ado, I'd like to introduce Dr. Van Thiel. Dr. Van Thiel, thanks for joining us today.
Thank you. Good afternoon, everyone. Looking forward to this. Hopefully, we're going to plow through quite a bit of information and really two goals of the presentation. One, to either refine or give people a good understanding of some of the shoulder conditions that we typically see in an injured worker, personal injury sort of setting, as well as hopefully give you a better understanding of where we develop causation opinions and treatment options for that. I do try and sprinkle in quite a few case examples of patients or of situations that I've been involved with, hoping to jog your memory, hoping to stimulate some thought in terms of current issues that you're facing. This always gets more fun if we are interactive back and forth, so feel free to put questions in, and Bill will direct us as we go. That being said, here's some requisite disclosures. Myself, I'm a sports medicine physician. I treat hip, knee, and shoulder issues, full range of workers' compensation, both from treatment to independent medical evaluations. I practice out of our Rockford, Illinois and Elgin, Illinois locations. And I always want to throw a big key into Injury Express and our urgent care that's actually staffed by physicians. That has been an excellent source of first level of treatment for not just patients in general, but a lot of injured workers as well. That being said, the shoulder is an extremely complex joint, and it's very difficult to determine causation. There's lots of different factors that go into it. Unfortunately, nothing is straightforward, including the treatment. And you probably see this almost every day for those of you that are out in the field or that are involved in treatment decisions, where you may have a similar looking MRI and get two very different opinions from surgeons or treating physicians in terms of what to do. And part of that is because there's just a really big gray area in terms of best options for various conditions. We always have to determine whether something's temporary, permanent, whether this was an aggravation, whether it was direct causation, whether this is just a normally progressive condition. Maximal medical improvement, end of healing, all those types of things are extremely important to start determining. And I think it's really critical to have a good diagnosis from the beginning, because we find that if you can get a good diagnosis from the beginning, it then establishes your treatment algorithms, it establishes your pathways, and probably most importantly, it establishes expectations from a treating patient in terms of what they can expect to be treated with, when our expectations are when they return to work, what various levels of work would be involved along that pathway. So this is always a dance. There's as much personal interaction oftentimes that goes into these types of treatment decisions, as well as patient interactions, as does actual pure medical decision making. Straightforward cases are pretty easy when everything really lines up. Complex cases are much more frequent, and they are hard, and they require a team. You certainly have to sift through things like motivation, secondary gain, pre-existing conditions, and really making sure everybody's on the same page, from the physician, the patient, the case manager, the adjuster, attorneys, whoever's really involved in that. If everyone understands the same thing, it tends to make it easier for all. It's very important to maintain what I call a linear thought process. And what I mean by that is, in order to determine what the best option is for people, we need to make sure that everything lines up. Was the mechanism of injury or the onset of symptomatology consistent with the reporting of that? Was it consistent with the initial treatment evaluations and the initial treatment provided? Does the imaging line up? And then ultimately, does the evaluation that we're completing, does all of that line up? If it doesn't, we just need to make sure that we're doing the right thing for the right condition. So here's some of the conditions that we're going to go through, again, with case examples sprinkled in here. So, if these are different issues that you're seeing currently, please feel free to put those in the question. So impingement syndrome, it's the dreaded bone spur or the bursitis. I would say probably about 20 to 30 years ago, the initial research came out showing that some extra bumps of bone on the acromion, which is the top part of the shoulder, may be impinging on the rotator cuff or the bursa below it, especially in over-shoulder-based activities, causing inflammation. We typically, in an injured worker or personal injury standpoint, think that the causation to impingement syndrome is typically repetitive over-shoulder work. Unfortunately, there's not great imaging correlations that go along with this. This is very much a clinical diagnosis. The treatment for impingement syndrome, education, injections can be very helpful into the bursa, anti-inflammatory medications, and physical therapy. We've not shown that operative intervention for the diagnosis of impingement syndrome or bursitis has very high success rates in terms of alleviating symptomatology. This is one of those tricky situations where oftentimes people continue to have some shoulder pain and that surgery can be defaulted to. But again, we just want to make sure that all risks and benefits and we have a true understanding of what the expected outcomes of that surgery would be. Typically, limitations during the treatment period would include no over-shoulder work, and maximal medical improvement would usually be reached around 6 weeks with no restrictions. So some cases that I think illustrate where this may be relevant and where it may not be relevant. So 60-year-old female cashier at a local hardware store, gradual onset of shoulder pain, had really had it for a while and then had been having an increase in shoulder pain, had actually seen an urgent care for shoulder pain and hadn't tied anything in terms of causation back to her work. She saw her primary care physician, and the primary care physician had actually suggested that this is most likely related to her work, at which point she reported it. This was approximately 2 to 3 months out. However, her work as a cashier, in terms of both her description as well as the job description, included no over-shoulder work, and the lift max was about 10 pounds in a normal day. So before I go on with that, this would be a situation where we know that the onset of bursitis or impingement can just occur in anybody. And this gets really difficult because a lot of us spend a lot of time at work. So if we have a progressive condition or a condition that's going to onset regardless of what we do, it's not infrequent that we start to first notice this at work. Now, that doesn't necessarily make it work-related. It can be, but just the onset of a personal medical condition while you're at work does not necessarily mean that work caused that personal medical condition. And that's where things have to line up. In this particular example, no over-shoulder work with a lift max of about 10 pounds would not be a mechanism that I would expect to either cause the onset of shoulder impingement or bursitis or cause an aggravation of pre-existing shoulder impingement and bursitis. So in this particular case, I would say, and again, there's always if there's anybody recording this, there's always different opinions, and there's always different cases, and each case is unique for sure. But in this particular case, I would say that mechanism of reported injury and the onset of symptomatology would not line up with a diagnosis in terms of a causation opinion with regards to the work resulting in this. So, if you pressed me on an opinion on this, I would say this was most likely not a work-related condition, and this would be just an onset of a personal medical condition. Second case is a 45-year-old male warehouse worker, stocked shelves frequently all day over shoulder level, reported pain at the end of a specific shift, didn't really report any one specific injury, but stated that his shoulder was bothering him at the end of the day. He ended up going to an urgent care 24 to 48 hours later. An MRI was performed, and oftentimes it's very common for an MRI to show some low-grade degenerative changes in anybody's shoulder. It's very rare for me to see a shoulder MRI that says normal MRI. And in this case, an MRI was relatively normal, some low-grade degenerative changes, as well as some inflammation in the bursa. Diagnosed with bursitis, underwent an injection, anti-inflammatory, physical therapy, and was back to work full duty at 8 weeks. This would be a case in that there was not any pre-existing symptomatology reported or treatment. The mechanism is consistent with one that would lead to a diagnosis of impingement, and he got better with the treatment. So this would be something where it'd be a little bit more clear and a good example of where impingement can occur in a work-related setting. This is another one as we wade into the personal injury space. 30-year-old female was involved in a car accident, had a few different injuries, treated for those different injuries, and then approximately 3 months out, started experiencing shoulder pain, reported the shoulder pain. An MRI did not show any large traumatic injuries within the shoulder, but had inflammation in the shoulder, underwent some conservative treatment for it, and reported this as involved related to that motor vehicle accident. This would be a case where a motor vehicle accident is certainly a mechanism that could result in the onset of bursitis within the shoulder for sure, but the temporal onset of symptomatology would not line up. So back to the concept of linear thinking, we've taken a bit of a turn here in terms of mechanism lines up, maybe the initial evaluation at that 3-month mark lined up, but the onset of that symptom or the onset of the condition did not necessarily line up. So this would be one we'd really want to look at some of the other things closely in terms of determining a causation opinion related to that motor vehicle accident. Rotator cuff tears, probably the most common condition in an injured worker setting or personal injury setting. These can be very complex, and it's for a lot of reasons. One, there's just a lot of people that use their arms for work. Two, most people over the age of about 35 to 40 will have some findings related to a rotator cuff on an MRI. And three, shoulder pain can just be really debilitating. So it's very important to determine the potential etiology of a rotator cuff. And again, this is back to that linear thought concept. But these can occur acutely with an injury, but oftentimes and probably more commonly, it's a slow onset of gradual shoulder pain. They'll typically note weakness. Pain at night is a very common complaint. People say, I wake up multiple times, not just rolling on that shoulder, but this is causing a lot of sleep disturbance. Usually related to lateral shoulder pain, referred over the deltoid, which is the big muscle. And they'll typically have full passive motion maintained, but be limited secondary to pain. So they'll be limited secondary to the active motion. And trauma with significant weakness is one that should be evaluated with an MRI, especially in a younger patient population, much more quickly than some of these other conditions. That can sometimes signify a very large rotator cuff tear, which there are different treatment algorithms for. So what causes a rotator cuff tear? We really don't know the answer to that. There's lots and lots of research, but a mechanism, sometimes falling, injury to an arm can certainly cause a rotator cuff tear. Lifting, pulling, these are all common things we see in an injured worker situation. But again, the most common reason for this is just really life. We don't really know what necessarily causes a rotator cuff tear. And I have some kind of interesting research here that I'm going to show you that may shed some light on your perspectives on rotator cuff tears. So there's definitely no right answer. Literature supports many different treatment options, from conservative, non-operative to surgery. Injections, I would say there has been some recent research that shows that in the setting of a full thickness rotator cuff tear, having done an injection can affect the long-term outcome if somebody ended up moving forward with surgery. So cortisone injections in the setting of full thickness rotator cuff tears are certainly still options, but a up and down discussion or risk and benefits discussion certainly needs to be had with that patient. We treat patients, not MRI reports. I see lots of people with MRI reports that don't look so great, but are doing really well clinically or have pain in a completely different location that would have nothing to do with the rotator cuff. Every patient is different, and this is where I think probably is the most insightful thing that we've learned in the research over the last 10 to 15 years is that rotator cuff tears are extremely common. Over the age of 60, there is a 50% rate of having a full thickness rotator cuff tear on MRI, and these were in asymptomatic patients, meaning that these people were doing fine. They were living their lives, doing everything that they wanted to do with no treatment, but an imaging confirmed a full thickness rotator cuff tear. So rotator cuff tears can be very common even outside of having had an injury or repetitive stress to that. Other studies have shown that asymptomatic 28% of 40-year-olds or 40 to 60-year-olds will have rotator cuff tears. And then again, you see the 54% over 60 had rotator cuff tears. So, what this really tells us is that there's often situations where people have had a rotator cuff tear for a very long time that were asymptomatic, that didn't have issues with it, and that became symptomatic. Or there are people out there that may have symptoms unrelated to the rotator cuff, but happen to have a rotator cuff tear on the MRI. So again, rotator cuff tears are not necessarily the direct result of a specific traumatic event. It may be inevitable for all of us. So imaging, when we start talking about determinations, factors that we use for causation, imaging in the setting of a rotator cuff tear is probably the most valuable. So there's a couple things that we can look at. So the longer a tendon has been torn, the more fatty atrophy that it develops within the muscle and the more retraction it has on the MRI. So basically, a rotator cuff tear or a rotator cuff that tears, that muscle loses its ability to function. And when it can't function, it starts to degenerate and it starts to turn from muscle fibers into fat fibers. And this is something that we can see on the MRI. This is what we call a sagittal view of the MRI. But if you look at the left screen, that red circle is circling something where there's a black circle surrounded by some white. That black circle is the rotator cuff muscle of the supraspinatus with a little bit of white that's around it. This would be very minimal fatty atrophy. And if we saw this in the setting of a rotator cuff, we would say, hey, that rotator cuff tear is probably a little bit newer or more recent. If you keep scanning over to the far right, all of a sudden that black circle has now gotten a lot smaller, and there's a much bigger white circle around that. All that white is fatty atrophy. In that situation, that rotator cuff has been most likely torn for a long period of time. So we see an injured worker, maybe 65-year-old worker that does some manual labor, has an injury to the shoulder, gets an MRI a week later, and we see that sort of imaging. We could say that that rotator cuff has most likely been torn for a long time based on the amount of fatty atrophy that's developed. The other thing is retraction. The longer a rotator cuff has been torn, the further it pulls back. So if you're looking for key words in radiology reports, retraction to the level of the glenoid is something that we commonly see, or moderate to severe fatty atrophy. Those would be all key words suggesting that there's at least some degree of a chronic process that's going on within that rotator cuff. And we just, again, need to make sure that we're looking at linear thought and that everything lines up if we're approving and providing treatment for somebody. So I always like to show a couple little surgical videos just in case sometimes it gets abstract for people that aren't involved in much surgery or aren't able to see these. But this is what a rotator cuff looks like. So right there with that instrument, I'm pulling on the rotator cuff. It should be attached right there. That's the top part of the arm bone or the top part of the humerus. And so I would say that looks like a pretty healthy rotator cuff tendon. That would most likely be a large acute tear of the rotator cuff. What we do in that setting is we prepare the bone below it. So the yellow is the bone. You see a little bit of bone marrow coming out of that. That's good for healing. And then we are basically making holes and putting anchors into those holes. There's different types of passing devices. So again, you see a needle type device as well as a grasper type device going through that white rotator cuff through different portals. And then that rotator cuff gets tied down. This is what we would call a double row repair, where that tendon that was free has now been tied back down to the bone. So just in a real quick nutshell, that's what a rotator cuff repair would look like arthroscopically. The other thing that we see a lot in these situations is partial tears. So again, if you remember that MRIs are never normal, it's very common to see partial tearing, high-grade partial tearing, tendinosis, intrasubstance tearing. Those would all be key words that we see very commonly on an MRI report. So the first question is, are partial tears real? And yes, partial tears can be painful, and they can sometimes even be more painful than full tears because there's an increased strain on the remaining fibers. So if you think of force going across a cable and you cut half that cable, the remaining half of that cable is going to be seeing all that pressure. And the same thing can happen with the rotator cuff. The right picture showing a pretty large partial tear where it looks like that rotator cuff is fully torn, but you can actually see the white below it, which is the inner part of the rotator cuff that's still there. So that's just a big example. They're oftentimes not that clear. These can be either bursal or articular, meaning they can be on top of the rotator cuff or below the rotator cuff. Non-op treatment is typically the first line of treatment. Oftentimes, again, because many people have partial tears of the rotator cuff, they can get better with things like anti-inflammatory medications and physical therapy. Operations are indicated when non-operative treatment fails and there's continued symptoms. If there's less than a 50% tear, and these are just general guidelines, we typically will debride that. We have started adding some biologic supplementation that I'm going to talk about here in a minute. If it's a greater than 50% tear, these are often the remaining rotator cuff is taken down and then it's treated like a full thickness tear. Success rates are pretty good with the treatment of partial tears, but even more so than a full thickness tear, everything really has to line up. Was that mechanism one that would be consistent with one that would result in a partial tear? Were the initial symptoms? Is the evaluation? Are all of those consistent with the MRI? Otherwise, we're going to end up treating people that may not be getting better. So here's the concept of why a partial rotator cuff tear can be painful, because you have one small remaining part of the rotator cuff, and that's seeing all the load or all the force through the shoulder. So what do you do with these? Different types of repair techniques. We can repair with leaving some of that rotator cuff intact. What you're looking at on the right picture, the lower part of that is the upper part of the arm bone, and the right part is a rotator cuff. Normally, that should be a pretty healthy white structure going down to that bone, and you can see there's quite a bit of fraying that's there. So this would be a rotator cuff tear that on MRI was slightly larger than 50%. If it's on the upper side, so this is the underside of the rotator cuff, that would be one where we more commonly take that down. And intratendinous would be one that we can treat like this side where we don't want to take down the good, healthy upper part. There's ways we can treat the inner part of that tear. And that's where biologic supplementation comes in. There's a growing body of research that shows that some of these biologic membranes or biologic patches actually have the ability to heal through the rotator cuff to improve both the health and actually heal some of these partial tears on both sides of the rotator cuff. So what does a repair look like? On the left side, the lower part of the screen is the top part of the humeral head. The left part of that image is the rotator cuff. On the right side, I'm now above that same part of the rotator cuff. So the lower right part of that picture, that's the intact rotator cuff. I've put a suture in there to mark where that partial tear looked like, but you can see there's no hole in that rotator cuff. So what I do in that situation is there's ways I can put anchors through the tendon itself without taking it down, and then create a construct where it's repairing that rotator cuff, the inner part of it back down to the bone without having to take down the good upper part of that. So that would be what we call a partial articular sided rotator cuff repair. This is also a good situation where these biologic patches can be used. So some of these biologic augments, which you're looking at here in the lower part of the picture, is an intact rotator cuff. But we know based on MRI and symptoms that there was a relatively high-grade intratendinous tear of the rotator cuff. So this patch is then brought in, and you can see this patch. And there's different things that these patches are made of. Some are made of porcine-derived tissues. Some are actually human dermal grafts. But you can see this patch is then deployed over the top of that area. Then it's going to be stapled in place right over the top part of that intratendinous rotator cuff tear. And the idea is that that patch then will actually heal into the intact rotator cuff and help with the health of it. There's been pretty good histologic as well as MRI follow-up studies showing that this is actually providing some significant improvement in both the overall thickness of the rotator cuff as well as healing of these partial tears. We will also use these to supplement full thickness tears because we think some of those same things are applying to the improvement of health of the full thickness repair. Pain relief is pretty predictable. Usually night pain is the first thing to go away following a rotator cuff repair. Function can be significantly improved, but it's less predictable in terms of especially a higher over shoulder level lifting. This can be a 12-month recovery. Typically, we start looking at maximal medical improvement or end of healing around the 6-month mark, but especially in a larger tear, this can sometimes be a 12-month process before we truly assign maximal medical improvement. The other interesting fact about rotator cuff tears that goes along with that fact that a lot of people have rotator cuff tears, we just don't know about it, is there's actually a relatively high failure rate of a rotator cuff repair on imaging studies. And so if you look the summary of that, you see the wide range in values, but at 2-year follow-up with different imaging modalities, including ultrasound and MRI, there's been reported to be an 11 to 95% failure rate of these rotator cuff tears or rotator cuff repairs. Probably the most interesting thing, though, is most of those studies and almost all those studies show that those re-tears on those imaging do not correlate with clinical function, meaning that functional scores have significantly improved following a rotator cuff repair, and those functional scores will stay good even with an imaging test that shows a re-tear of that rotator cuff at the 2-year mark, which is, again, just shows the complexity of the treatment of these conditions, and that you would think that if something re-tore, somebody would go back to the baseline symptoms that they were having prior to that repair, but we don't necessarily see that as the case. People can continue to do well even with an imaging that shows re-tearing of that rotator cuff. So the injured worker or personal injury case, traumatic event or heavy repetitive over shoulder work is typically the mechanism that we see that lines up with rotator cuff pathology. It may have been there before, and this gets really difficult when we start talking about aggravation. Was this a temporary aggravation of what was a pre-existing large rotator cuff tear, or was this a permanent aggravation of what was previously an asymptomatic smaller rotator cuff tear? MRI can help us determine chronicity through some of those things that we talked about before. And you can have a temporary aggravation of a pre-existing. Just because somebody has a rotator cuff issue does not necessarily mean that that was a permanent or a direct causation related to whatever they're reporting as their injury mechanism. So restrictions following a rotator cuff repair, typically no over-shoulder work, lifting restrictions for 6 weeks, followed by progressive light-duty lifting restrictions up until 6 months, at which point we start evaluating for a full-duty return. In large rotator cuff tears, unfortunately, there are potential permanent restrictions, usually related to over-shoulder lifting, depending on the lifts that are required in the job description. So some cases that over the last 10, 12 years or so I've been involved with that just seem to, I think illustrate some different points. 80-year-old male with shoulder pain after a car accident, and a shoulder replacement was recommended. The question was, did the car accident result in the need for the shoulder replacement? So if you just look at this on the surface, typically a shoulder replacement would be done in the setting of arthritis or in the setting of a non-repairable rotator cuff tear. 80-year-old, if you remember back to some of the initial studies that we talked about, very high rates of having rotator cuff tears as we age. This person had actually had some pre-existing treatment that was maybe a year or two before for some shoulder pain. Again, every case is unique and different, but an 80-year-old male with an MRI that shows fatty atrophy of the rotator cuff with a rotator cuff tear retracted to the level of the glenoid with actually moderate level glenohumeral arthritis is in a car accident with no fracture. I think the chance that that car accident caused a permanent aggravation of that well-established pre-existing condition based on MRI and some of the pre-existing treatment would be pretty low. So, again, every case is different, but this would be a situation where I would say that there's pretty good evidence based on the imaging, based on the pre-existing treatment, based on the mechanism, based on the patient characteristics, that probably this did not cause this rotator cuff tear that is resulting in the recommendation for replacement. 55-year-old male stalker has been at the job for 6 months, begins to complain of shoulder pain. MRI shows a large rotator cuff tear with significant fatty atrophy. So I would say there's a few different components to this. So one, 55-year-old male, still a relatively young patient. A stalker, assuming that this is a more manual labor job that requires lifting, pushing, and pulling. So I would say the age and the job duties would be ones that would be consistent with potentially causing rotator cuff pathology. At the job for 6 months without one specific injury, starts to question a little bit. So 6 months potentially it can potentially cause rotator cuff pathology, but we typically like to see a little bit longer manual labor use. The onset of shoulder pain with no injury, and then the MRI shows a large rotator cuff tear with significant fatty atrophy. So outside of having had a major injury, being at the job for 6 months, significant fatty atrophy and large rotator cuff tears would not typically develop over that timeline. This would be one where this is where it takes a turn, where all of a sudden everything seemed like it was lined up, but this MRI would suggest that there was some pretty significant pre-existing rotator cuff pathology. So that would certainly need to be taken into account when determination with regards to causation is made. 62-year-old female slipped and fell in the aisle at a department store, no pre-existing shoulder pain, had not had any treatment for the shoulder pain, has the onset of shoulder pain, seeks treatment right away at an urgent care, undergoes physical therapy. MRI shows a rotator cuff tear with no fatty atrophy. I think everything lines up in this case. The MRI is suggesting an acute process with no fatty atrophy. Mechanism of slipping and falling is consistent. Failure of conservative treatment, no pre-existing symptomatology. This would be one where everything lines up and is probably directly caused as a result of this reported injury. So this takes us into glenohumeral arthritis, which we've seen a really large increase in, especially in an injured worker population, whether people are working for longer or whether this is getting to be more mainstream. I'm sure some of you have seen recommendations for shoulder replacements out of injured work settings, and this is a little bit different than knee or hip replacements. Typically, the progression of End-stage osteoarthritis is usually related to a normal progression of a pre-existing. There's only unique situations where that would be worse in the hip and knee. In the shoulder, it's a little bit different because our indications for shoulder replacement are different. We do have some research. We did some research a while ago that showed that actually because the glenohumeral joint or the shoulder joint's a non-weight-bearing joint, it can actually respond to arthroscopic procedures where we can clean up some inflammation, we can release some different structures to improve motion, and that people can show improvement. We know in the setting of severe knee arthritis or hip arthritis, this is not the case, but the shoulder seems to be a little bit different. So shoulder replacement, rule of two. So as I go through these different slides, you'll see that there's really kind of two components or two different aspects when we start talking about shoulder replacement. So the first important thing to understand is that there's two types of shoulder replacement. One is called a total shoulder replacement or an anatomic shoulder replacement, and the other is called a reverse total shoulder replacement. And if you look at the two x-rays below, you can see the difference. The one on the left is the total shoulder or anatomic shoulder replacement, and the one on the right is the reverse shoulder replacement. You can see that on the one on the left, that metal ball is replacing the metal ball at the upper part of the arm bone, whereas on the right screen, that metal ball has actually been switched over to the cup side, and the cup is now at the top part of the arm. For lack of getting into too complex of a discussion, the reason that this works is because the deltoid muscle, which is the big muscle on the outside part of your arm, does help with arm motion, but it usually does not engage in an initial arm motion. So when you try and lift your arm up from your side, and some of that has to do with the lever arm, by doing a reverse replacement, you change the center of rotation of the ball by switching the sides, and that increases the lever arm of the deltoid, which allows that muscle to start working and it allows that muscle to start working when the rotator cuff would normally be working. So a reverse replacement basically makes the rotator cuff not necessary because it can use the deltoid to do those motions. So there's two different types of arthritis that can develop. One is primary osteoarthritis and one is rotator cuff tear arthritis. The difference is that the primary arthritis, the ball is rubbing on the cup and it wears away the cartilage or the cushion, leading to arthritis. In the second rotator cuff tear arthritis, that rotator cuff, because it's torn, allows that ball on the right x-ray to start moving up. When it starts moving up, it starts to rub against the bone on the top part of your shoulder where it normally would not rub, leading to a different type of arthritis. So there's two different types of arthritis that can develop in the shoulder. So you can see where it's rubbing on that bone and it's actually creating basically another cup or a secondary cup in that upper bone. So that leads to two reasons for a shoulder replacement. So shoulder arthritis, which you're seeing in the image there, very well understood in the knee and the hip, can lead to the recommendation for a shoulder replacement in order to replace the arthritic parts of the shoulder. However, what makes the shoulder unique is that rotator cuff dysfunction or rotator cuff tearing can lead to the recommendation for a shoulder replacement as well. So if you have a rotator cuff that is torn and can't be repaired or the likelihood of it healing is very low, doing a reverse replacement can allow that deltoid to take the place of the rotator cuff. So it basically fixes the rotator cuff by not requiring it to be used anymore. So that's where we see the use of reverse shoulder replacements in a worker or a personal injury setting, in that in a rotator cuff that can't be treated with repair, a reverse shoulder replacement can be a good option in that case. So this gets complex in terms of determining who fits into what category and what caused that need for the shoulder replacement. So a 65-year-old male works at a hardware store with lifting to shoulder level with occasional lifts above shoulder level. Has had shoulder pain for a few years, but had been able to work. Was lifting a box over shoulder level and started having pain that day that worsened throughout the day. Reported the injury, sought care, treatment with his primary care doctor, anti-inflammatory medications, and physical therapy. So if we just back up a little bit and we look, so there was some pre-existing symptomatology in the shoulder, but there was also a mechanism of lifting over shoulder level in someone that uses their arms at work that could be consistent with a rotator cuff injury. So we already have some multiple different facets to the decision making. So with the failure of conservative treatment, an MRI was ordered. MRI report was a massive full thickness rotator cuff tear with retraction to the glenoid and moderate fatty atrophy of the supraspinatus and infraspinatus. So this would fall on the far right side of the MRI images that we went through before. A massive full thickness tear of the rotator cuff with that level of retraction, with that level of fatty atrophy, would not indicate that this was an acute process that had happened more recently, but rather a long-standing process. And so then the determination needs to be made based on multiple factors, which gets very, very complex, and each case is different, in terms of whether or not this was just the normal progression of a pre-existing condition that was going to occur regardless, or whether or not this was something that would not have progressed and did not progress outside of his work-related injury. And so certainly an argument could be made both ways. I won't give a specific answer to this, but you can see the argument that could be made on both sides of this. But each side has a valid argument. So this is certainly not a clear case of, oh yeah, he had an over-shoulder lifting incident at work that caused the onset of this pain that he started treating with, and now he needs a reverse shoulder replacement as a result of the work injury. There's certainly a discussion on both sides. So this is actually his treatment. So the shoulder replacement, we kind of went through all of this. So, we kind of talked about the different options that had and the different issues that need to be made. So there's just lots of factors that go into it, and certainly nothing ever is perfectly clear. So 70-year-old female works as a cleaner, obese and a smoker. We know obesity, smoking, and diabetes tend to affect the rotator cuff. Was moving a chair, felt a pop and pain in the shoulder, did not have any pre-existing shoulder symptomatology or previous treatment. Went to an urgent care that day, an MRI and PT were ordered. X-ray showed moderate arthritis in the glenohumeral joint. So no pre-existing treatment, but X-rays show moderate arthritis in the glenohumeral joint. So I would say that as we go through this, that moderate arthritis was definitely a pre-existing condition that was not caused nor aggravated as a result of the moving the chair when she felt a pop. MRI showed a large tear of the supraspinatus with minimal retraction and mild fatty atrophy. So we have a large tear, could be chronic, could be acute. We have mild retraction or minimal retraction. So minimal retraction would suggest that was more of an acute process and not a long-standing process. Mild fatty atrophy would also suggest that would be more of an acute process and not necessarily a long-standing process. So you have somebody who's 70, who we know a lot of these people have rotator cuff tears just based on the research provided earlier, but was doing pretty well before this incident, has a mechanism of moving a chair with feeling of a pop that's, I would say, consistent with a mechanism that could result in an injury to the rotator cuff, has some arthritis in the shoulder on X-ray, but then has an MRI that looks like it's probably more of an acute tear of the rotator cuff. Referred to orthopedic, surgery was recommended, and this person underwent arthroscopic rotator cuff repair. Given that there was minimal retraction and mild fatty atrophy, I think a good indication for repair. I would probably argue, if you put me on one side of this, it probably was related to that injury based on the MRI and the mechanism. Unfortunately, this is a case that we sometimes see in these patients as they get older. 9 months later, continues to have pain, continues to have limited motion. Repeat MRI shows a recurrent rotator cuff tear with retraction to the glenoid and moderate glenohumeral arthritis. So we now have a 70-year-old with a recurrent rotator cuff tear with continued symptoms and an inability to return to their previous level of employment. Unfortunately, we know that once somebody has a rotator cuff tear, there are, like we talked about before, relatively high rates or real rates of having potentially recurrent tears of that rotator cuff. And so now the argument is, the recommendation is for a shoulder replacement. Is that shoulder replacement due to the arthritis that's in there that's experiencing normal progression, or is it due to that rotator cuff tear? Is that recurrent rotator cuff tear related to some of her underlying conditions, including age, obesity, smoking? Or is it related to the fact that that initial tear unfortunately just did not heal, which we know is a known complication? If again you put me on one side of this, I would probably argue this is related to that initial rotator cuff tear that unfortunately went on to not healing with continued symptoms. So this may be one where a shoulder replacement is actually indicated as a result of a work-related injury, whereas we don't typically see this sort of story for knee and hip replacements. So these are all the things that we kind of talked about going into that. So restrictions after shoulder replacements usually have some degree of permanent restrictions. I do have people that have returned to full duty after restrictions, but there's usually some job-specific stuff. Generally speaking, we limit over-shoulder lifting with usually a 50 or less pound weight limit for lifting restriction on a shoulder replacement. One of the last things I'm going to get into here is just slap tears. Again, it's something that we see pretty commonly on an MRI. There can be degenerative slap tears or acute slap tears. The MRI can give us some information regarding that. Usually this is anterior shoulder pain, anti-inflammatories, surgery for a slap tear. Certainly over the last 10 years, we've learned that repairing these slap tears, because that's right where the biceps is attaching onto the labrum in the shoulder, because that biceps continues to pull on that slap or on that tear of that labrum, failure rates are 25 to 35% in patient populations over the age of 25 with repairing that labrum because of that continued pull. Whereas if we do a biceps tenodesis, it significantly reduces those failure rates and improves functional outcomes, and the recovery is actually quicker. So the typical treatment for a slap tear, where everything lines up in terms of a mechanism, the imaging, and the failure of conservative treatment, would be to complete a biceps tenodesis. So you can see on this image arthroscopically, this would be what a slap tear would look like. That biceps is attaching onto the labrum, which is the white line coming in at the top of the image. And you can see that that labrum is lifting up off of the glenoid or the cup. And you can imagine that as that arm moves and that biceps pulls on that labrum, it's causing some pain and discomfort. Whereas if we remove that biceps attachment, it's going to allow that labrum to heal and render it asymptomatic. They can be degenerative, and again, everything lines up. Restrictions, no over-shoulder work with a weight restriction for 6 weeks. Surgery is typically a little bit of a quicker maximal medical improvement than a rotator cuff. With a biceps tenodesis, we see that occurring at around 3 months or so afterwards. So what I'm going to do is I'm going to pause here and see if we have questions that people would like addressed. Certainly those are fun tangents to take, so if we have some questions, we'll take those. If we don't, I can run through my quick talk on the state of orthobiologics.
So there's one question from Amy asking, at what age do you not perform slap tears or the slap tear repairs, or is that really going to depend on the patient?
So it's going to somewhat depend on the patient, but I would say in my personal practice, it would be very rare for me to perform a slap repair over the age of 20. Even, people that are in their mid-20s. Now, the one caveat to that would be if they're very heavily involved in an over-shoulder sport, and that's either they're playing it at a professional, semi-professional, or an extremely high-level recreational level. We will consider doing a repair in that 20 to 30-year-old age group, but if you made me press on an age, it's very rare for me to repair any slap tears over the age of 20 because we know the failure rates associated with those repairs.
That was it for right now. We've got a couple other questions that I see are typing in. Do you want to do your biologic real quick?
Yeah, and feel free to interrupt me. So orthobiologics is something that we see in the upper extremity, probably a little bit more than we see in some of the other extremities. And orthobiologics is what I'm going to refer to as stem cells. I don't necessarily like using the term stem cells because I think it's a bit of a misnomer and it's more of a marketing push than anything else. So where are we in this? Well, I think it's first to understand what orthobiologics are. Per our academy, these are biologic substances that are found naturally in the body that can improve healing. Really, there's two different forms. So I tell people there's two different sources of these types of orthobiologics. One's called allogenic and one's called autogenic. Allogenic means that it's from a donor or from somewhere else other than you. Autogenic means that it's from you. The first level is something called PRP, which again is probably seen most commonly. What PRP is basically taking somebody's own blood, and I'm going to go through all of these. BMAC is using your own bone marrow. This is a little less common, but adipose-derived cells are when you basically take some fat cells from somebody, and all of these are the autogenic options. And then allogenic is when we get into the amniotic fluid and placental membrane-derived cells, which would be donor-based cells. Each of them have different characteristics and reported uses and reported outcomes, and they all are delivered a little bit differently. So what aren't orthobiologics? So orthobiologics do contain stem cells or mesenchymal stem cells, but they also contain a lot of growth factors that we think may even be more important than those stem cells in terms of function. And we definitely have to be careful. This is a little bit the wild, wild west. We're starting to get a better handle on it more recently, but when we get into the allogenic stem cell lines, placental and amniotic fluid, there's not a lot of regulation around that, and that's certainly growing. So what is PRP? So it's an autologous concentrate of the patient's own blood injected into soft tissue or joints in order to promote healing responses. Most of the research, both in vivo and in vitro, meaning in patients and in the lab, shows that this typically works because it reduces inflammation. So I describe PRP to my patients as a natural way of reducing inflammation and promoting healing. What it does not do is it does not provide stem cells that regrow things that we want it to. And the best analogy that I give to people is, yes, we do have access to stem cells. Where we haven't crossed the bridge yet is telling a stem cell what to be when it grows up, meaning that if we inject a stem cell into a knee just because we want it to become cartilage because we're missing cartilage does not necessarily mean that it's going to become cartilage. It could just as easily become ligament or scar tissue or capsule or bone or some of these other things. So stem cell deviation or the growing of stem cells into specific cell lines, that is where the next jump is going to be. And unfortunately, we're probably a long ways away from that based on regulatory pathways. So you can see what taking blood looks like. This then gets spun down and injected. There are actually pretty good research studies around PRP in the setting of arthritis, that it can significantly reduce pain when compared to either a placebo or a cortisone injection. And we think that that's occurring because of the natural reduction in inflammation that occurs. There's also specific situations, lateral epicondylitis, proximal hamstrings, some varying research in rotator cuffs that shows that PRP is a good natural way of stimulating a healing response, whereas cortisone reduces inflammation but does not necessarily promote healing. That PRP can promote a healthy healing response that can help somebody get to the end of whatever problem they're having. I think probably the most powerful data is in the setting of lateral epicondylitis in the elbow, where it's been shown in multiple studies to be more effective than other treatment options. Bone marrow aspirate, it was big for a little while. It's still out there, but not quite as big. Part of it is because of it's a bit tedious to collect the bone marrow aspirate. It's usually done from the iliac crest. Sometimes it can be done under local anesthetic. Oftentimes it's done in surgery. Bone marrow is really pretty similar to the blood that's used for PRP, but it just has higher concentrations of stem cells, as well as higher concentrations of some of those growth factors. So it may be a bit more effective. There's not nearly as many studies on bone marrow aspirate as there are in PRP in terms of the injection treatment. There's probably a little bit more studies on bone marrow aspirate in terms of regarding surgical augmentation, meaning augmenting a rotator cuff repair with bone marrow aspirate. And I think that some of it is getting stronger. I would say it's not definitive, but it's certainly growing, suggesting that some of these bone marrow aspirates can provide some improved healing of various conditions. But again, a lot more research to do. Adipose-derived stem cells, based on some FDA stuff, have gone away. I think this is much less common. We don't see this as often in orthopedics. And then allogenic, amniotic, placental-derived cells are really the off-the-shelf stem cells that we talk about. In each one of these slides, the price point has gone up and up and up. This is by far the most expensive. And this is where we don't have a lot of regulation around that. We know that there are mesenchymal stem cells associated with this, and there's some case reports or low-grade evidence that suggests that there may be some benefit in this. I definitely have had patients that I don't do these right now because I don't necessarily think the cost is worth what the research shows in terms of benefits for patients. I definitely have people that swear by it and they say, you couldn't help me and I got this stem cell injection, I feel great, and I think that's really fantastic for them. I think those people work, that they're doing great with it. I definitely have people that come in that say, I spent $10,000 on different injections and I don't feel much different than I did before. And those are definitely the two ends of the spectrum, but you can see the level of frustration because these are not insurance covered products. The Amniotic membrane has demonstrated anti-inflammatory, antimicrobial, and antifibrotic potential, meaning that it can reduce inflammation and that it can help prevent scar tissue or help stop more inflammation from occurring. So again, probably functioning as some degree of a more natural anti-inflammatory, albeit just at a higher price point. And these products are injectable, are available in multiple different suspensions. They can be done in multiple different settings and multiple different joints for multiple different conditions. And so, again, there's people that online, you'll see lots and lots of really positive things. I think the downside of this is the cost associated with it. We haven't seen recently really bad side effects as we saw maybe 7 to 8 years ago in terms of infections based on the lack of regulatory criteria around the production of these. So, I think it's an exciting place for there to be research that continues. There's definitely a lot of hope for a lot of people that have conditions that maybe we don't have the perfect answer to. I'm just not sure that we're there yet, but definitely there's some studies that suggest some interesting things that we need to explore further. Where we see orthobiologic use currently, osteoarthritis, do a fair amount of PRP for arthritic conditions in the knee, in the shoulder, in the hip, especially in patients that say, I've been through cortisone, I've been through viscosupplementation, I'm not ready for a joint replacement. And again, the research shows that these people do pretty well with that. Rotator cuff repairs, we see a lot of bone marrow aspirate being used to augment the repair. Part of the reason for that is you see this giant potential opportunity to improve how we do rotator cuff repairs. Based on that research we showed at the beginning that shows there's pretty high failure rates or re-tear rates of the rotator cuff. Even though that doesn't necessarily correlate with clinical outcomes, we definitely have room for improvement in how we can make rotator cuff repairs more robust with better healing rates. That's where some of those biologic patch augmentations come in. That's where things like bone marrow aspirate come in. They're all good ways in an area where we certainly have room for improvement. Lateral epicondylitis, I think, has the strongest research with PRP showing that it really does more effectively treat the condition better than anti-inflammatory medications, physical therapy, and certainly cortisone injections. So that gives us hope. There's definitely, opportunities for these types of orthobiologics to provide people a lot of relief where maybe we don't have good options for them. We just need to understand it better, and that will come with time for sure. With that being said, I already talked about the PRP. There was a really good systematic review that looked at all the PRP studies out there when comparison with hyaluronic acid or viscosupplementation and placebos, and found improvement in functional outcomes. So that was a pretty powerful study, or a systematic review is an accumulation of multiple different studies. With that being said, I will really stop this time and see if there's any additional questions that popped up.
We do love doing these webinars. We do love educating our customers. We've got another one coming up in about a month. Dr. Logley is going to talk about cutting-edge in-office treatment for carpal tunnel syndrome. There's a QR code right in your screen right now. You will get an invite in the email before the end of this week as well. But if you want to scan that, you can go ahead and get registered for that webinar right now. I'll give you a second or two. For any questions about workers' compensation, referrals, or to learn more about our Fast Track program for injured workers, please see our website, OrthoIllinois.com, and click on Employers. In Elgin, Algonquin, McHenry, and the greater Chicagoland area, call Paul Strandquist at 815-847-7088. For Rockford, North Central Illinois, and Southern Wisconsin, call me, Bill Collar, 815-847-7044. One quick question for you, Dr. Van Thiel, and it's a great one from our audience. Smokers and surgery. How does smoking affect your surgical plan, surgical outcomes? Are there any surgeries that you would not perform if your patient is a smoker?
Yeah, I think, smoking, we see more and more evidence that it affects soft tissue healing for sure. I would say that where I see it most relevant in my practice I do a lot of cartilage restoration as well as rotator cuff repairs because you're seeing that already we have relatively high rates of not healing, and we think that has to do with a biologic process in the rotator cuff. So anything that's going to affect that biologic process is going to affect those healing rates. So certainly in the setting of a large rotator cuff tear, we do want people to stop smoking, and we do test that before as well. So we require them to be not smoking before the surgery, and before we'll put them on the surgical schedule, they'll have to undergo a test to make sure that they have not been smoking. So there's ways that we can do to test that. So cartilage restoration and rotator cuff repairs. Now that gets a little bit difficult in an injured worker setting, because if they say, I'm just not going to stop smoking, we run into this chicken problem where then can we never do their surgery, or how do we move forward? So there's always a gray area, and that's where a risks and benefits discussion needs to come into play. But in the ideal situation, especially with any rotator cuff tear, but definitely a large tear, we would have people stop smoking beforehand.
We've got about 30 seconds left here. Same question, kind of, but what about vapes, tobacco, even cannabis? Is smoking, or does it matter what vapor is there?
I wish I knew the answer to that. So we think right now that there's some biologic issues, especially with vaping and smokeless tobacco. But we just don't have big enough studies to say whether or not that's true or not at this point. So currently, I'm not doing anything in terms of limiting those. We're really just focused on smoking, because that's what we have the research around.
Dr. Van Thiel, we are at 1 o'clock. Thank you very much for your time.
Thank
Everyone
you,
who was in attendance, thank you for your time. As soon as I end the webinar, which will be in just a second, please make sure to leave your browser open. You should be taken to the survey. If you have any questions, email me directly, billc@orthoillinois.com. Thank you.
Thank you all.